we know that physical activity is so beneficial for so many cardiovascular conditions. A lot of what my research is now is really focusing on how do we get people to move more. There are so many strategies in behavioral economics that are useful for this.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. I have the distinct honor and privilege of having with me Dr. Alexander Fanaroff. I've been a huge fan of his work. And I think what I found inspirational about him is that he somehow manages to hit every late breaker, which I managed to fail somehow. So I'm sort of the fanboy for Alex. And to introduce Alex to our audience, he's an interventional cardiologist, he's a clinical trialist, and a behavioral economist. He's assistant professor of medicine at University of Pennsylvania, and he's here on Parallax to talk to us or educate us about adherence, medication adherence when it comes to prescription medications in patients with a myriad of cardiovascular disorders, or we can focus on interventional cardiology in patients post-acute coronary syndrome who've had, percutaneous coronary intervention performed. And before I have Alex speak, another fanboy moment for me was when he was, and you can correct me if I'm wrong, Alex, I think you were one of the winners or you were one of the finalists, certainly for the Linnemeyer Award at TCT, which I applied every single year till I was eligible and I was never picked. So, a lot of respect there. So with that introduction, Alex, welcome to Parallax and thank you for doing this for us.
Yeah, thanks so much for having me.
Of course. So let's start off. The part about your portfolio, which I found most fascinating as we were discussing offline, and I wasn't aware of this, is that you are a behavioral economist. Tell us more about that, because I think it has implications on the topic we're discussing.
Yeah, so behavioral economics is sort of the study of how people make decisions in the real world. There's sort of this traditional microeconomic idea of how people make decisions, which is that they're essentially supercomputers and they take in information and integrate it and sort of make an optimal decision. And what behavioral economists did, really starting in the 80s and into the 90s, and these are people like Richard Taylor, and man, now I'm blanking on sort of the big folks in the field. Richard Taylor is one of the big ones. They sort of realize that people don't make decisions in that way, and that instead people are really limited in the decisions they make by limited information and limited time, especially. And so ultimately, what you end up doing is, instead of making an optimal decision, you do what's called satisficing, which is making a decision which is good enough, where you sort of exhausted the time and resources you have to make the decision, and then you just sort of you make a decision that's good enough. And the way people make those decisions are through heuristics or rules of thumb, and these sort of shape our decision making and lead us many times in the real world to make decisions that are not optimal. Some of the big ones which we can talk about are status quo bias, or just the idea that people don't really change. They sort of are willing to go with the default options. Prospect theory, which is this idea that people value losses or are hurt by losses more than they value equivalent gains. And then immediacy, which is the idea that people discount things that are far into the future more than they probably should. So those sorts of things are how people make decisions. And what we do in behavioral economics is we study the way that those biases affect decision making, and then we try to design interventions in such a way that we make use of those biases to help people make decisions that are consistent with their stated values, or what they say they want.
Thanks for going over some of these topics, and particularly behavioral economics, in terms of how you see its applicability to what we do in our daily practice. For example, taking care of STEMIs, and you want you want excellent adherence to medical therapy because now you've put a stent in, and you certainly want the patient to be on. We're not going to discuss duration of DAPT here because that's outside the scope of this talk. Say you want them on uninterrupted dual antiplatelet therapy for maybe 3 months or maybe 6 months, and how does behavioral economics play a vital part in determining or ascertaining adherence to, for example, DAPT post PCI?
So I think that the classic way that maybe a microeconomist would think about this is that they would say, well, people are not adherent to DAPT as much as they should be. Why is that the case? And they would conclude that people are thinking that people go through the risks and the benefits, and they decide that it's just not worth it to continue DAPT. And and the response to that would be to do more education, because we want to really show people that there's a benefit of DAPT and they should be taking it. But I think when you think about it from a behavioral economics standpoint, you have to say, well, people know they know they should be on DAPT. They know it's important. We tell them when we put the stent in, hey, listen, you got to take your P2Y12 inhibitor and your aspirin so that your stent doesn't thrombose. And people don't want their stent to thrombose, so they know they're supposed to be taking DAPT. And so what you think about as a behavioral economist is, well, what gets in the way of that? What are the when people come to the point where they're making the decision to take or not take their P2Y12 inhibitor, 3 days or 3 months or 6 months after their PCI, what is preventing them from doing the thing that they know they should be doing? And I think that it's a complex question. But so what we do as behavioral economists is we break it down, right? So, um, every there are concepts in behavioral economics about nudges and sludge, and what we try to do is we try to change the environment so that and a nudge is something that pushes somebody in the right direction, and sludge is something that pushes somebody to do the wrong thing or what they don't want to do. And so, in the case of adherence to P2Y12 inhibitors, something like needing to refill their prescription is sludge. It's friction in the system that makes things harder. And so, one of the things that we've done is, this was focused on statins and not P2Y12 inhibitors, but it's the same concept, is there's data out there that suggests that people who fill 90-day prescriptions are more adherent than people that fill 30-day prescriptions. And this makes sense. The default when it comes time when you run out of prescription is not to do anything. The default when you run out of your medicine is that you take the last pill in the bottle, and if you don't do anything, you won't get any more medicine. So the more times that people have to overcome that default and act and make a decision, the less likely they're going to be to remain adherent and to stay on their medications. So there's evidence that if you give people 90-day prescriptions, they'll be more adherent to their medications. And so what we actually did at Penn is we took that a step further, and we did this with statins, and we said, well, why aren't people getting 90-day supplies of medications? Why aren't people getting 90-day supplies of statins? And it turns out that about 70% of people at Penn that were prescribed statins were getting 90-day supplies. But when we looked at the way that the order was in the electronic health record, the default did not populate a number of days to fill the prescription. So what we did is we changed the default prescription length to 90 days, a 90-day supply with three refills, and we increased proportion of patients that got 90-day supplies from 70% to 90%. And that's one example of how thinking like a behavioral economist can help you overcome some of these barriers to adherence. Where how do we make it easiest for physicians to do the right thing, prescribe the right duration of prescriptions, in order to make it easiest for patients to remain adherent?
Interesting. So, do you think the reverse psychology works? And I'll explain to you what I mean. I mean, for example, we often counsel our patients to stop smoking, right? So that is sort of non-adherence to smoking, right? And adherence to medication. How would a behavioral economist think about helping people to stop smoking? Because they know smoking is injurious to health. They know smoking is tied to adverse outcomes, not only from a cardiovascular perspective, but also, as the etiology for a multitude of cancers. I think I shouldn't say this on a medical podcast, but the only condition I read during medical school in the red pocketbook of medicine where smoking may help is ulcerative colitis, and that too was a question mark. So how would a behavioral economist decode this problem of like reverse psychology when it comes to adherence, because we want patients to not adhere to smoking?
So smoking is really challenging, obviously, because it's like there are behavioral components, there's a chemical component to addiction. It's really challenging. The thing about smoking, in the context, there are a few things that I think are relevant, for smoking in the context with behavioral economics. So the first is that there's this idea in behavioral economics of the fresh start effect, which is this idea that people are more motivated to change behavior, um, in when something new is happening. And the classic example of this is our New Year's resolution. So everyone goes to the gym in January, and then they obviously stop. Um, for people that have an MI is a fresh start. I mean, they're in the hospital. They can't smoke for a few days. So and they're really motivated to change. So one thing is to really, is to jump on that opportunity and to say, well, here's an opportunity to change. And I think that a lot of our patients do change. The question is just the question becomes like, um, how do you have them continue to be abstinent from smoking? And I think, there's, I think there's some of it, there's obviously some evidence for smoking cessation programs um, and medications and things like that. The things that I've seen that are the ideas from behavioral economics that come into play here, um, that I've seen used, are one really interesting idea that's actually very effective but hard to get people to do is something called a commitment contract. So what you do is the classic idea of this is people, you have somebody put money down and say, I'm putting a meaningful amount of money, $50, $100, $500, depending on the patient, um, and saying, if I smoke in the next 6 months, I lose that money or I donate it to a charity I don't agree with. And when people do that, they're actually really effective at quitting smoking. The challenge is just that no one wants to do that. Um, so our group at Penn has sort of done this in slightly different ways. Where one way is you have people, you give them a sum of money, you put it in a virtual account for them, and if they successfully quit smoking, they can keep the money. So that takes some of this idea of prospect theory, or the valuing of losses more than gains into account. But these are some of the ideas that have been used. Smoking remains a really challenging problem, um, to solve. But those are some ideas that I think researchers have looked into to try and increase smoking cessation.
So Alex, I know that you've done some seminal work in at the intersection of behavioral economics and implementation science when it comes to interventional cardiology. Um, what is new and upcoming in your work? Because I mean, you clearly are an incredible thinker, and your some of your papers have been very innovative. So what's new in your world right now?
I think that what's most interesting to me, we've done a lot of work with physical activity, and we know that physical activity is so beneficial for so many cardiovascular conditions. In the realm of primary prevention, we know that it is associated with a reduced risk of cardiovascular events. In secondary prevention, we know that in people with heart failure and people with PAD, that it can improve symptoms, it can improve functional capacity, um, and so a lot of what my research is now is really focusing on how do we get people to move more. Um, And uh, and behavioral economics is there are so many strategies in behavioral economics that are useful for this, um, and that we've tested in a number of studies. And so I think that the sort of the first study that we did, or the most recent study, the biggest study we did was called Be Active, where we randomly assigned people to, or we gave them all Fitbits. We had them establish a baseline daily step count, and we had them set goals to increase their physical activity by a certain amount, and then we randomly assigned them to sort of uh, either a control condition where they just tried to meet their goal, um, a financial incentive where we gave them $14 each week and they lost $2 each day that they didn't meet their daily step goal, or a gamification intervention where we gave them points each week and they lost points each day that they didn't meet their step goal, and progressed through levels based on their points accrued. And it turns out in that study that, in the gamification arm, where we didn't give them any money and we just had them progress through a game that was based on concepts from behavioral economic theory. We gave them the points, we gave them a fresh start each week, that they increased their step count by almost 2,000 steps per day over a 12-month intervention. And so that was exciting, because that's a meaningful increase in steps. And what we're doing now, I'm running a trial, taking the same gamification intervention and applying it to people with heart failure with preserved ejection fraction. Um, to see whether it increases physical activity and also, quality of life and functional capacity as measured by the KCCQ and the 6-minute walk distance. Uh, we just finished a trial in patients with PAD, showing that it increases physical activity in patients with PAD. And the next step being to look at, whether it improves PAD specific quality of life, and 6-minute walk distance and other meaningful functional measures. So, um, and I think that, what techniques for behavioral economics combined with wearable fitness trackers and things like that, it enables us to really design what I think are pretty effective interventions that can reach people in their homes, and can increase physical activity meaningfully. Maybe not as meaningfully as cardiac rehab or supervised exercise, but in meaningful ways, that are going to be inexpensive, accessible to patients, and ultimately, I hope, improve their quality of life, and then, hopefully, and it can reduce cardiovascular events. So that's what I'm excited about.
Yeah. So, Alex, for someone who's interested, who wants to sort of build literature in this space and, wants to operationalize some of the work that you're doing. And I mean, certainly you've, you have, a body of work to represent what you've done here. But if someone wants to get into this space and do it, operationalize this, how do you, like, in terms of how to implement this, what are the nuts and bolts, to operationalize this on the ground? What would that look like?
So I think it depends what you're trying to operationalize. There are certain things that are simple, and they can be done through sort of design choices in the EHR that we work with. Um, so you know the study that I was talking about, where we changed the default prescription length, that was just like a small coding change in Epic. We've also done things where we increase statin prescribing to appropriate patients just by, using Epic to make lists of all patients that should be on statins and weren't, and having pharmacists call them. And so some of this stuff is sort of having clinicians that are at the front lines, and that can think about, um, why patients fall through the cracks, why patients aren't treated correct, why patients aren't treated, the way that we know we should treat them, and why physicians aren't doing the things that they know they're supposed to be doing, and thinking about this um, in new and creative ways. Um, I think that a lot of people, when they hear the word nudge, they think about, Epic users think about best practice advisors, those things that pop up and tell you that you're doing it wrong. Um, and I would just encourage people who are trying to do this in the real world to think beyond that, and to think about, how can you change defaults in your Epic system? How can you change How can you make things as less intrusive to physicians or providers as possible, um, while still steering them towards doing the right thing for the patients. And I think thinking thoughtfully about defaults in the electronic health record um, are is a good way to do that. We're not there yet, but like when we have LP little a targeted therapies, and still like 1% of people in the US are getting LP little a checked despite recommendations from the National Lipid Association. you know One way that you could approach this, if it ever becomes a class 1 recommendation in the guidelines, one way you could approach increasing LP little a screening is to say, well, I'm going to put a pop-up in there every time a patient sees their primary care doctor that says check LP little a. But the other way you could do it is you could say, well, if somebody has a lipid panel ordered and never had an LP little a tested, we're just going to default that an LP little a is ordered. So I think that one way is just to think creatively about, what does choice architecture look like? How do you change the way that decisions are presented to people? How do you use defaults effectively to steer people in the right direction? So I think that's one thing we think about implementing this in the real world. The other thing is that we're lucky enough at Penn to have this program called Way to Health, which we use in all our physical activity studies, which sort of automates some of the um, behavioral economic concepts, and sort of automates the processing of incentives and capture physical activity data and things like that. Uh, it's hosted by Penn, but it's actually a resource that anybody can use. You can just go to waytohealth.org and sort of, if you have funding, we can design a study that uses concepts from behavioral economics and automates the delivery of incentives and financial incentives or social incentives or what, sort of flexibly, however you want to do it. So those are some of the tools that we use, and I think that those are tools that are available to folks working out in the community and elsewhere.
Excellent. Alex, what in terms of implementation science and interventional cardiology, I mean, I know you've shared your work in peripheral arterial disease. What is the next frontier, you think, with across the spectrum of all of interventional cardiology? It could be peripheral vascular interventions, could be transcatheter valve interventions, could be coronary interventions. What is the next frontier when it comes to implementation science, behavioral economics, and what we do in the cath lab?
Yeah, I think it's an interesting question. It's hard for me as an interventional operator to necessarily think about how you're going to use behavioral economics or implementation science to change people's behavior in the cath lab, because we we're well trained, and I think that you know we do the right thing most of the time in the cath lab. To me, I think that the place where implementation science and behavioral economics can help is in making sure that our patients are optimally medically managed and getting the care that they need, outside of the cath lab, or getting the patients to the cath lab in the first place. There's been a lot of really interesting work, I know, um, looking at um, identifying people that are likely to progress, that have moderate AS and are likely to progress quickly to severe AS, or looking at people that are likely to have, or looking at people that have severe AS diagnosed on an echocardiogram and are not referred to the cath lab. Um, to me, thinking about how to close these barriers or close these gaps in delivering the care that we need, and getting people that should be in the cath lab or should need these procedures, getting them to get their procedures and to get the testing they need is, to me, that feels like the biggest gap. So I think that, finding people out there with severe AS that we're not treating, um, diagnosing PAD earlier, and getting people on appropriate medical therapy. Um, you know, uh, there's going to be a whole host of AI programs that are reading CT scans and identifying coronary calcium, um, getting those people on appropriate medical therapy. So to me, that really feels like where where this intersects with interventional cardiology, is honestly thinking about our role uh, more as cardiologists, and in how do we identify people for procedures and then give them the best care that we can after the procedure, and in some ways develop systems so that people don't fall through the cracks, and honestly making our jobs easier as interventional cardiologists.
Super. And talking about gaps, and maybe we can end the episode on this note. Yeah, disparities are real, right? They exist. We've there is an incredible body of literature that now um, has highlighted um, that they exist. Do you think your approach, with behavioral economics can help us narrow that disparity gap? When it comes to not only patients we treat in the cath lab, but also primary prevention.
Yeah, so I think that there are ways that it can. Um, so we talked about how I talked about how we changed default prescription length um, for statin prescriptions in the EHR at Penn. Um, what I didn't say is that before we changed the default prescription length to 90 days, um, Black patients, Hispanic patients, patients with Medicaid, and patients living in zip codes of low socioeconomic status were less likely to get 90-day prescriptions than white patients, patients with higher socioeconomic status, and patients without Medicaid. Um, After we changed the default prescription length, everybody was equally likely to get 90-day prescriptions. So in that sense, interventions that improve quality also tend to reduce disparities. And we saw some evidence of that. We see some evidence of that in sort of the door to balloon initiative. It reduced disparities in STEMI care. So I think that that's one way that I think that implementation science and interventions that improve quality of care can reduce disparities. Just a rising tide lifts all boats. Um, the second way I see it happening is that, when thinking about physical activity, we know that people with lower socioeconomic status are less likely to be able to access cardiac rehab for a variety of reasons. If we can create something that doesn't involve having to go to a center, doesn't involve co-payments, doesn't involve needing specialized um, physical therapists or anything like that, then theoretically that intervention is going to be as accessible to somebody in uh, West Philadelphia or Central Mississippi as it is to anybody in the country. So you're talking about using um, technology to offer care to people that might otherwise struggle to access it. So, in that sense, I think there is some promise in sort of using these ideas to reduce disparities. Um, Frankly, I think that the history of how disparities have arisen and how they've been perpetuated would tell us that it's not going to be enough, and that we have to think about specific interventions targeted towards uh, historically underrepresented and communities that historically have struggled to access medical care, um, and to really design interventions specifically to improve their care. And I think that there's a role for behavioral economics potentially in developing those interventions. Um, so I think that it's a combination of all those things, but I think that you know behavioral economics is an important part of implementation, and implementation is obviously necessary to close some of these disparities that we've now been describing for 20 and 30 years.
Fascinating. Well, Alex, I mean, you're clearly a leader in the space, and we have much to learn from you. Keep up the great work that you're doing, and um, I think we'll be watching your space and your work evolve as time goes on. Any closing remarks for our listenership, for what they should look for from your work, and any closing remarks for Parallax?
No, thank you so much for having me. This was a pleasure to be on.
Of course, and for those tuning in, if you have any questions for Dr. Fanaroff, do write to us. We'll forward those questions to him. Do review us and rate us on any of the podcast platforms that you access to listen to us, whether it's Google Play, SoundCloud, Spotify, Audible, what have you. We take your comments seriously. And until other Monday, goodbye, everyone.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.